Hello, my name is Mr. Nisarg Mehta, CT1 in Trauma and Orthopedics. Today we're going to be talking about the surgical anatomy of the elbow. This is especially important when evaluating children with suspected supracondylar fractures. The elbow joint is a complex joint that has numerous blood vessels and nerves, all of which can be damaged in a supracondylar fracture. A sound knowledge of anatomy is therefore extremely important and will aid you in assessing and managing children with supracondylar fractures. In this tutorial, we're going to look at the bony elbow joint, the contents and margins of the antecubital fossa, and the three principal nerves in the upper limb, the median, ulnar, and radial nerve. We will also briefly look at associated nerve lesions that are applied to supracondylar fractures that you should be aware of. The picture here demonstrates a view of the elbow. This is a bony view of the elbow, and it is very important to familiarize yourself with the basic anatomy, the osteology of the elbow. The lower end of the humerus, which is this bone here, bears the rounded capitellum, which can be seen here. This articulates with the radial head, which is nicely demonstrated here, and the spoon-shaped trochlea medially, which articulates with the trochlear notch of the ulna. The medial and lateral epicondyles, which are seen here and here, are extracapsular. The medial is the larger of the two, and it extends more distally and bears a groove on the posterior aspect for the ulnar nerve. Just round here, you can't see that on this picture. It is an important and practical point to note that the lower end of the humerus is angulated forward by 45 degrees on the shaft. Any decrease of this angulation indicates a backward displacement of the distal end of the humerus and is good radiographic evidence of a supracondylar fracture. The radius consists of the head of the radius, which articulates with the capitellum, the neck of the radius, the radial tuberosity, which serves as an attachment of the biceps tendon, and the shaft of the radius, with the styloid process as the most distal palpable prominence. At the elbow joint, the three surface anatomy landmarks would be the lateral epicondyle, the medial epicondyle, and the olecranon posteriorly, which you cannot see on this radiograph. Pause for a minute and have a feel of these three bony landmarks in your own body to familiarize yourself with these three landmarks. The elbow joint, although a single synovial cavity, is made up of three distinct articulations. These can nicely be seen here. The humero-ulnar articulation, which is between the trochlea of the humerus and the trochlear notch of the ulna. This is a hinge joint. The humero-radial articulation is between the capitellum and the head of the radius, and this is a ball and socket joint. And the proximal radio-ulnar joint, which is a pivot joint that is held together by the tough annular ligament. And that, in essence, is the bony anatomy of the elbow. We will now move on to assess the cubital fossa. The cubital fossa is triangular in shape and thus has three borders. A large muscle here, the brachioradialis, forms the lateral border of the antecubital fossa. Medially, it is formed by the pronator teres, and superiorly an imaginary line going between the epicondyles of the humerus. The floor of this fossa is formed proximally by the brachialis and distally by the supinator muscle. The roof contains skin and fascia, which is reinforced by the bicipital aponeurosis, which can clearly be seen here. Within the roof runs the medial cubital vein. I'm sure you will be familiar with this vein, as this is the vein that is commonly accessed for venipuncture. The contents of the cubital fossa include vessels, nerves, and the biceps tendon from lateral to medial. The radial nerve, now this is controversial as some do not consider this to be a part of the cubital fossa, but it is extremely relevant to supracondylar fractures. It passes underneath the brachioradialis muscle to divide into the superficial and the deep radial nerve. The biceps tendon can clearly be seen here, which runs through the cubital fossa to attach to the radial tuberosity, which was seen in the previous image. A major vessel in the cubital fossa is the brachial artery, which is nicely seen here. The brachial artery supplies oxygenated blood to the forearm, and it enters the cubital fossa, subsequently supplying and deviating into the radial and ulnar arteries. And lastly, one of the most important structures is the median nerve, which leaves the cubital fossa between the two heads of the pronator teres, which can be seen over here. The median nerve is a major peripheral nerve of the upper limb, and we shall look in detail of the course of the median nerve in the next couple of slides. Have a look at your own arm now and see if you can palpate the various structures of the cubital fossa. We now move on to the median nerve. This is a very important peripheral nerve of the upper limb. We should look at the applied anatomy of the nerve, the anatomical course, motor functions, and cutaneous innervation. We will also apply this to damage of the median nerve, which can occur with supracondylar fractures. The median nerve arises from nerve roots C5 through to T1. The main motor functions of the median nerve is that it innervates the flexor muscles in the anterior compartment of the forearm, except the flexor carpi ulnaris and parts of the flexor digitorum profundus. It also supplies innervation to the thenar muscles and the lateral two lumbricals. Sensory functions, it gives rise to the palmocutaneous branch, which innervates the lateral aspect of the palm, and the digital cutaneous branch, which innervates the lateral 3.5 fingers on the anterior surface of the palm. It is important to understand the anatomical course of the median nerve, because this nerve is commonly damaged in fractures of the supracondylar region of the distal humerus. The median nerve originates from the C5 to T1 nerve roots, and it is derived from the medial and lateral cords of the brachial plexus. After originating from the brachial plexus, the median nerve descends down the arm. It can be seen here. It initially lies lateral to the brachial artery, but then halfway down the arm it can be nicely seen to cross over to lie medial to the brachial artery. The median nerve enters the anterior compartment of the forearm via the antecubital fossa, which can be seen here. In the forearm, the nerve travels between the flexor digitorum profundus and flexor digitorum superficialis muscles to give rise to two branches. The anterior interosseous nerve supplies the deep muscles in the forearm. The palmar cutaneous nerve innervates the skin of the lateral palm. The median nerve proper continues and enters the hand via the carpal tunnel, where it terminates to give two branches, the recurrent branch of the median nerve and the palmar digital branch, which innervates the palmar surface of the fingertips and the lateral 3.5 digits and lateral 2 lumbricals. The median nerve innervates the majority of the muscles in the anterior forearm. In the anterior forearm, the median nerve innervates the pronator teres, flexor carpi radialis, and palmaris longus, and flexor digitorum superficialis. The median nerve gives rise to the anterior interosseous nerve, which supplies the deep flexors, which are the flexor pollicis longus, pronator quadratus, and the lateral half of the flexor digitorum profundus. The median nerve is responsible for the cutaneous innervation of the hand via two branches, the palmar cutaneous branch and the digital cutaneous branch. Median nerve can be damaged at the elbow secondary to supracondylar fractures. Damage of the median nerve is often associated with a classical sign which can be seen in the slide called the hand of benediction. Let's understand how this occurs. The median nerve supplies the flexors and the pronators of the forearm, except flexor carpi ulnaris and the medial half of flexor digitorum profundus. These flexors are therefore paralysed, apart from flexor carpi ulnaris and the medial half of flexor digitorum profundus. Flexion of the thumb is prevented because the longus and brevis muscles are also paralysed. The lateral 2 lumbrical muscles are paralysed, and as a result, the patient will not be able to flex at the MCPJ or extend at the IPJ of the index and middle fingers. Sensation would therefore be at the areas that innervate the median nerve. As a patient therefore tries to make a fist, only the little and ring fingers can flex. This results in the classical sign known as the hand of benediction. This can be seen as a late sign in supracondylar fractures, and one should always be wary of median nerve damage. The ulnar nerve is also a major peripheral nerve in the upper limb. It is derived from the brachial plexus as a continuation of the medial cord. It contains the fibers of C8 through to T1. After arising from the brachial plexus, the ulnar nerve descends down the medial side of the upper arm. At the elbow, it passes posterior to the medial epicondyle before entering the forearm. At the medial epicondyle, the nerve is easily palpable and vulnerable to injury, especially during supracondylar fractures. In the forearm, the ulnar nerve pierces the two heads of the flexor carpi ulnaris muscle. 3 branches therefore arise in the forearm. The muscular branch innervates muscles in the anterior compartment of the forearm. The palmar cutaneous branch innervates the skin of the medial half of the palm. And the dorsal cutaneous branch innervates the medial 1.5 fingers and associated palm area. Within the anterior forearm, The ulnar nerve supplies the flexor carpi ulnaris, which flexes and adducts the hand at the wrist, and the medial half of the flexor digitorum profundus, which flexes the fingers. As you can recollect, the remainder of the muscles of the anterior forearm are innervated by the median nerve. The majority of the intrinsic muscles are innervated by the deep branch of the median nerve. In the hand, these include the hypothenar muscles, the medial two lumbricals, adductor pollicis, and the interossei. There are three branches of the ulnar nerve that are responsible for cutaneous innervation. The palmar cutaneous branch innervates the skin of the medial half of the palm. The dorsal cutaneous branch innervates the skin over the medial one half of the fingers, and the superficial branch over the palmar surface over the medial half of fingers. Let us now talk about the ulnar nerve lesions at the elbow. These can occur during fixation of supracondylar fractures. The ulnar nerve is most susceptible to injury at the elbow and the wrist. The ulnar nerve supplies the flexor carpi ulnaris and the medial half of the flexor digitorum profundus, which will be paralysed. Flexion of the wrist can occur, but is accompanied by abduction. As the interossei are also paralysed, abduction and adduction of the fingers cannot occur. Movement of the little and ring finger is greatly reduced due to paralysis of the medial and two lumbricals. Because all sensory branches are affected, there will be a loss of sensation over the ulnar nerve distribution. Some people commonly confuse the ulnar claw with the hand of benediction, and I've briefly put up a table demonstrating the differences between the two. The ulnar claw characteristically is caused by ulnar nerve damage at the wrist. The interossei are paralysed. Abduction, adduction of the fingers cannot occur. The ulnar claw consists of extension of the metacarpophalangeal joints of the little and ring fingers because of paralysis of the medial two lumbricals and unopposed action of the extensor muscles. One also sees flexion at the interphalangeal joint. However, if the lesion has occurred at the elbow, this might not be evident, as the flexor digitorum profundus will be paralysed. The hand of benediction only occurs when the patient attempts to make a fist, and one sees inability of the flexion at the MCP and IPJ of the middle and index fingers. It's important to know that the ulnar claw is a chronic sign, often with long-standing ulnar nerve problems. We will now move on to discuss in brief the radial nerve. The radial nerve is a major peripheral nerve of the upper limb. It originates from the nerve roots C5 through to T1 of the posterior cord of the brachial plexus. The nerve arises in the axilla to exit posteriorly to the brachial artery. Here it supplies branches to the long and medial heads of the triceps brachii. The radial nerve then descends down the arm, travelling in a shallow depression on the surface of the humerus. This depression is known as the spiral groove, which can be seen here. Fractures of the mid-shaft of the humerus are associated with damage of the radial nerve in the spiral groove. As it moves inferiorly, the radial nerve wraps around the humerus in a lateral direction and gives a branch to the lateral head of the triceps. During its course in the arm, the nerve is accompanied by the deep branch of the brachial artery. To enter the forearm, the radial nerve moves over the lateral epicondyle through the cubital fossa to divide into two branches. The deep branch or the posterior interosseous nerve, innervates the muscles in the posterior compartment of the forearm, which are the deep extensors, and the superficial branch, which contributes to the cutaneous innervation of the hand and the fingers. The sensation of the radial nerve is by means of 4 cutaneous nerves. The lower lateral cutaneous nerve of the arm innervates the lateral aspect of the upper arm below the deltoid. The posterior cutaneous nerve of the arm innervates the posterior surface of the upper arm. And the posterior cutaneous nerve of the forearm innervates a strip of skin down the middle of the posterior forearm. Finally, the superficial branch of the radial nerve innervates the dorsal surface of the lateral 3½ digits and the associated palmar area. Injury to the radial nerve can often occur in 4 groups depending on where the damage has occurred. In the axilla, all 4 cutaneous branches of the radial nerve are affected, which causes loss of sensation over the lateral and posterior upper arm, posterior forearm, and the dorsal surface of the lateral 3½ digits. Triceps will be paralysed, and the patient is unable to extend the forearm and the wrists and fingers. Unopposed flexion of the wrist occurs, which is called a wrist drop. In the radial groove, the triceps is weakened but not paralysed. The posterior interosseous nerve is affected, so the muscles of the forearm are paralysed. A wrist drop occurs. I have not discussed in detail the radial nerve palsies, as this is a subject that is to be discussed in another podcast, not in this session. I hope that you have gained some knowledge of the anatomy of the forearm. The next section of the workbook will test your knowledge and reinforce the knowledge you may have learnt on the anatomy of the forearm and the associated nerves. Thank you very much.